Good afternoon and welcome to our Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. I'm very excited to introduce our guest today as we speak about cardiology. Dr. Long Cow has been a provider with Oak Bend Medical Group since 2017. He is board certified in internal medicine and cardiovascular disease. He is also certified in echocardiography, nuclear cardiology, and vascular interpretations. With a passion for teaching, Dr. Cow was an associate professor for medicine and a public speaker where he enjoys speaking on cardiac disease and cardiac prevention awareness. Well, it's a great day to have you today because it is actually World Hypertension Day. So welcome, Dr. Cow.
Thank you, Donna, for having me. And I want to say hi to everyone out there. Good afternoon or good night, wherever you are. But yeah, it's great to be on here, and especially on Hypertension Day, so we can talk about it.
Well, and we have some questions arranged for you because, you know, we don't often see cardiologists or know when to see cardiologists or what. So my first thing would be, when should we see a cardiologist?
I think if you have symptoms, you should see a cardiologist. And symptoms don't have to be just chest pain. It could be shortness of breath. It could be palpitations. It could be dizziness. I have some patients, and actually most of my patients coming in, they say that they feel unwell. They feel fatigued. They feel like, last year they were different. This year they're much different in terms of being able to do things. So it's not always a clear cut, I have chest pain, and that's what you need to come in for a heart doctor. Some people come into me because they have a family history. Parents just had some event, or siblings, and they're worried. They want to catch things ahead of time. So in terms of age, most people start developing a lot of heart issues at age 45 onwards. Men especially, we have higher risk factors. Women much later, however, still can have it. But I'm beginning to see a lot of folks come in their early 30s. Sometimes I get very young folks coming in between 18 and 30 with congenital findings because they had some complaints of not performing in school, or not being able to do certain things and getting dizzy, passing out, and things like that. So I don't think age or should be a criteria. I think, if you have symptoms, if you have a family history, come in. It doesn't hurt to talk about it. You may find something. I can give you a specific example. I had a gentleman come in. He's very young. He's actually has family members that work in the hospital, but he was in his 20s. He came in passing out every year when he went to the bathroom, and he thought that was normal, And he ended up finding, we ended up finding Wolff-Parkinson-White, congenital conduction pathway that leads to sudden death. And, he was able to be treated and it's okay. So it could be as minimal as that. I mean, it surprises me what I find in certain young folks, and that's why Oak Bend does screening annually on young folks before sports activity and whatnot. And believe it or not, we found some folks with issues that we were able to get to and help them get the right help that they need.
So is heart disease genetic?
There is a genetic component, but there's also an environment component. So there's both, right? And I would say, if you already have genetic predisposition, you need to work hard on your environmental issue, eating right, exercising and whatnot. But if you have good genetics, you can still go south if you don't take care of yourself. If you're eating fatty foods, if you're smoking, if you abuse your body, then genetics can only go so far. So it's both very important. But yes, heart disease, there is, and a lot of folks come into me with family history of heart disease, and it could be from arrhythmias to early vascular disease, plaque in their vessels. Not because, there's a genetic marker to develop plaque. It's just they have a genetic component to higher cholesterol, a genetic component to blood pressure being higher earlier in age. And those things contribute to vessel disease. So it could be direct or indirect, a genetic component relatively. And also, again, environment plays a huge role. So, don't be in despair if you have a family history. You can pretty much change that if you work out and do your best to maintain your health. And vice versa, just because your genes are good doesn't mean you can go abusing your body.
So I have a question. We've certainly been battling COVID, and no one knows that better than you. So we've had patients come in, and now we're seeing some after effects. Do you think it's a good idea if you've had COVID or suspect you've had, just to come in and get checked or go to your...
Yeah, I would definitely do that because, before I wouldn't say that, but recently, one is I just had to do my research examination for my board certification. And in doing so, we had to have a few credits, updated readings so that we keep up to date. There is so many journals from JACC and from major journals, New England Journal of Medicine, talking about COVID and its effect on the heart during your infection and after your infection. Amazingly, I didn't believe this at first until I read all of that. And I'm seeing it firsthand too. Before we would see clots, and you probably out there hear about it. When you have it, there's clots. Clots can form in your lungs, in your legs, in your heart, causing a heart attack, causing pulmonary embolism. And then afterwards, we found out heart failure. So a lot of the virus does, and we think, it goes and it affects the gut, but it also affects the lung. Now we're finding it has an actual direct effect on the heart muscle. So some people end up with heart failure. And actually, we do an echocardiogram while patient, an ultrasound of the heart while patient has the infection to help us evaluate prognosis, because it does affect the heart. And a lot of the heart stuff doesn't come till afterwards. So I have a lot of folks that come into me saying, "Doc, I had the infection. I'm still tired. I feel weak. My legs are swollen," heart failure symptoms. We would do an assessment on that. And some of them do have standing issues with their heart. Others come into me because they still feel palpitations. They feel like their heart is racing. And again, same thing. There's certain residual effects that are there that predisposes them to arrhythmias as well. So there is so much that we're finding down the pipeline. I don't want to say there is, big studies out there, but I guarantee you within the next few years, there will be, as we're getting over this infection and we're doing post studies, we're going to find out more evidence and more information regarding this. But definitely viral pneumonia or COVID does have you can call it an indirect, or now we're finding more direct effects on the heart.
So, and that's interesting because that brings me to like diabetes and some other things. There are certain diseases that imply that you could have heart disease further down the road.
Yeah.
So should we be getting in with a cardiologist and having a platform? Because is it preventable or can it be prolonged, I guess is the question.
Yes. So if you come in early, it is preventable because we're learning more, right? Before, you used to think bad eating habits, what we talked about earlier, not exercising, genetics being a marker for heart disease. But then when you dive into the cause of it, because a lot of patients will come into me and say, "Doc, so how does plaque, or how does, your vessels, accumulate this grease or this plaque or this yellow stuff inside the vessel?" And, they would go into far as, I have some friends that are skinny and they have heart disease. Then I have some friends that are very obese and they don't have any heart disease. This doesn't make any sense. It's because we never understood this well. And I didn't understand it until we observed it while I was studying and doing my training and fellowship is, exercise and diet is very important. Don't get me wrong. However, understanding why plaque is there is very important. And it boils down to inflammation. So that's your key, inflammation, just like cancer, inflammation. And inflammation is caused by high blood pressure. Think of your vascular system as pipes. And those pipes, when you're younger, are very compliant. They stretch and they give and take, and they're easy. They don't break easily. But as you mature, your pipes get hard and it's subjected to pressure. But remember, you get upset, your pressure goes up. You eat a lot of salt, your pressure goes up. Now the pipes, those vessels in your heart can't stand that pressure. It will crack. And, in looking at the vessels, it usually tears. We call it intimal injury. And that causes a cascade of inflammation. Again, inflammation. And that draws fat, calcium, cells that fight infection to the area where there's the tear or the cut in your vessel. And it tries to heal it. It heals it, and then it leaves behind, dirty stuff. Your cholesterol, old clotted blood, and that forms the plaque. You say, well, what's with that and diabetes? Well, diabetes is sugar in your bloodstream. It doesn't need to be in your bloodstream. Diabetes is when, the sugar is too much. It's floating in your bloodstream and your muscles aren't utilizing it. And you have this excessive amount of sugar in your bloodstream, which is Not good. Sugar doesn't belong in the blood vessels. It should be absorbed by your muscles in your body and used for energy. But when you're diabetic, it's floating around. Well, think of it as an irritant. It irritates the vessel. It causes inflammation in your vessels. Again, inflammation, and you have plaque development. The same thing goes for lupus, rheumatoid arthritis. You have people who have autoimmune disease also have a higher risk for heart disease. And then finally, kidney damage, end-stage renal disease. They build up all this toxin. Their heart vessels harden sooner, so they are more prone to injury of their vessel and development of more vessel disease or plaque. So yes, definitely, if you have diabetes, if you're a smoker, if you have high blood pressure, you have high cholesterol, if you are end-stage renal disease, you have something that prones you to inflammation. Definitely, if you can go in, get evaluated, get tested early so you can fix whatever has already happened, or get prevention treatment, meaning stricter control of your risk factors. For example, if someone comes in and they have blood pressure of 140, and if they want to prevent, then they need to get their blood pressure, in the 120s very strictly versus other folks. Same thing for diabetics. We're more strict on them, and people with cholesterol. People who have heart disease with cholesterol are prone to plaque. We want their LDL less than 100, sometimes less than 70. And then those who don't, then we're willing to give it to 130 or 160, depending on how much risk factors. So it definitely matters how strict you treat a patient if they have risk factors for vessel disease or plaque development. So definitely go in, seek help, seek an evaluation if you have risk factors.
So I have heard at times people will say, I've had this bad indigestion, or I'm not feeling well, or I think I have GERD. But then you hear, I had a slight heart attack. Or how does somebody know if they're having a heart attack?
That's a good point, Donna. I get that all the time. And first of all, if you're feeling that something is not right, go seek help, because, the worst thing is they can find acid reflux, but at least you're not having a heart attack. A heart attack will kill you or severely debilitate you if you're not treating it early. And so that's not something to take lightly, because that's your entire life. Yes, it could be acid reflux, but acid reflux doesn't kill. The heart will. You don't want to mistake in that. So first off, if you have any doubt, come in. So now, how do you tell the difference between that and the heart? So there's a few telltale signs with the heart. You have to think of it as a pump. The heart's a pump. If it doesn't give enough blood to your body, you're going to feel tired. You're going to feel dizzy. You're going to feel nauseous. If it doesn't give enough blood to itself, you'll have pain, chest tightness. And some people don't have just chest pain. They'll have shoulder pain, jaw pain, back pain. Diabetics don't present the same way. Women don't present the same way as men. And even men, some of them don't have straight up chest pain. They'll have what we call silent heart attacks. But the other things will show itself. You'll feel short of breath, you'll feel dizzy. And it gets worse with exertion because you're demanding more of your heart. So if you feel like, oh God, if I walk faster, if I do more, I feel bad. And when I rest, it gets a little bit better. Then you got to think it's your heart. With acid reflux, it doesn't get worse with exertion. It gets worse after eating a fatty meal. With muscle pain, you can point to it, and sometimes you can reproduce it. You can make it better by massaging it, by raising your arm, sometimes making it worse by movements like that. But with the heart, it isn't. It's an inside pain. It doesn't matter how you move your arm. It's going to hurt. It's going to feel like pressure. It's going to feel those symptoms. But there's also other symptoms that go with it. If it's muscle pain, you shouldn't feel short of breath or dizzy. If it's acid reflux, the same thing. So you got to look at the whole context. If you just think about a pump, if it fails, what happens to your entire body? And you get the big picture of that. The other thing is, usually with the heart, it keeps gnawing at you. It'll keep telling you, hey, I'm here, I'm present, deal with me. With the other stuff, like acid reflux or muscle pain, you'll have good days and you'll have bad days and it'll go away. But with the heart, you'll notice, oh, I've been having this for the last month. It's just every other day, every week, it just doesn't want to go away. That's a sign that something is not right. It's going to get worse, or there's something there, and you want to focus on that, especially if you have risk factors. So definitely look beyond just having chest pain.
So don't be scared or embarrassed to come in. Always be safe.
Yeah, I would say so, right? If you're banking on something, this is your life you're playing with. There's no second chip around. So, I mean, it's better to be wrong, and, your life is safe than, to be wrong the other way and not come in and you put your life at risk, So there's nothing embarrassing about it, especially when you're worried about, something in your gut that says, hey, something's wrong.
So is that the same thing with, sometimes you'll hear people say, I feel flutters in my chest?
So flutters in the chest can mean something wrong with the heart, but certainly fluttering can be, the heart rhythm. Some people have fluttering when they have palpitations, or they can feel this fluttering inside their chest, or this movement that is a little bit off. All of us, we don't normally sit and feel a rhythmic movement in our chest, but when we feel it, it's sometimes the heart is acting up. It's pounding harder. It's moving faster. It's moving in an irregular rhythm. It's hitting against the chest, and you feel that fluttering. Sometimes I get patients that don't have any issues when I examine them or do an EKG, an electrocardiogram on them, and they have that fluttering because their muscles twitching. That's the benign finding, but it could be that you have an arrhythmia. So if you feel some fluttering in your heart and you're dizzy, or you have other symptoms, or just fluttering by itself, it doesn't hurt to come in for an EKG, just to make sure you don't have any arrhythmia, because there's a few silent things I always go and talk about. One is a silent heart attack, and we talked about that. But there's other silent disease in the heart, like irregular rhythm, like AFib. A lot of folks that we found with irregular rhythm of their heart have a higher predisposition for stroke. And we don't find out about the AFib or the irregular rhythm until after they've had the stroke. That's where the silent killer comes in. So they don't know to take aspirin. They don't know they have an abnormal rhythm. The most they'll know is they'll notice this little fluttering in their chest. And if you ignore it, you can have an abnormal rhythm that can cause a stroke at home and not deal with it. And then by the time you notice your face is drooping, or your arms are weak, or you're having numbness and tingling, it's already too late. And that's the unfortunate part, is a lot of the strokes we find is associated to an abnormal rhythm that people may have picked up and they kind of ignored it. Now, there are other ones that don't pick up anything. And that's also another reason why when you go to a doctor, especially a cardiologist, but your general doctor, sometimes they do an EKG annually. Mainly because some people are just silent. They don't feel anything, no abnormal rhythm in their heart. And that's the only time the heart doctor does an EKG and finds they have an abnormal rhythm. That's why we do it. We don't do it just because, but we do it because sometimes it's silent. You just don't know. And that's very preventable. It's a stroke risk that's very preventable.
This is all such good information. So now I have another question. You're just making me ask all these questions. So we talk about having plaque in the heart and atrial fib and all this stuff. But what about our legs and other parts of the body? Because our neck, I would imagine if we have plaque in the heart, it doesn't just concentrate there.
Yeah, definitely. When we think about plaque or a clot in the heart, it's a heart attack. If it's in the head, it's a stroke. If it's in the leg, it's ischemic leg disease. The legs are not as, reported, because you don't die because of your legs. You may lose your leg at the worst, or develop an infection, and that can be, life-threatening, but it's not like as dramatic. And so people don't emphasize, other parts of the body that can get a plumbing issue. Just think about your whole body. Your heart has plumbing, but your entire body has plumbing. Blood has to go there. And as cardiologists, as cardiovascular doctors, we're often thought of as only the heart, but we're talking about the entire vascular system, So wherever blood needs to go, we're in charge of that. Wherever the plumbing is, we're in charge of that. So certainly if you have other plumbing issues, and that could be carotid disease of the neck, your increased risk for strokes, or you feel those pulsations in your neck, or, you just feel a whooshy sound in your neck, maybe you need to have that evaluated. If you had a stroke history already and you're like, why did I have that stroke? Is it just bad luck? Is it abnormal rhythm, or is it this? You should go have that checked. If your legs are swollen, and they're swollen, could be bad veins, could be bad arteries, or if they're painful too, you should have it checked, especially if you have a wound that aren't healing. You have discoloration besides swelling in your legs, showing chronic swelling. Maybe there's something wrong with the veins. Maybe there's a clot in the veins. If you have Charlie horses all the time, you're like, oh, okay, sometimes I don't drink enough water. That should happen. But why am I getting it every time I walk? And if it's hurting like crazy when you go home at night, when you rest your legs after a day of not having enough blood flow to your legs, those are what we call claudication. And, you need to have that checked out, because you don't want to end up with an infection or a wound before you find out you have bad blood flow to your legs, because that could mean an amputation. By that time, it's too late to save your leg. So, don't just think about the heart, think about the entire vasculature, and not to mention aneurysms. Some people have aneurysms in their stomach, in their chest, this tube that carries blood from their heart all the way down to your entire body, your arms, everywhere. That big tube can be aneurysmal, big, and a normal size is around 3.5. And when it goes beyond that, it's abnormal. And when it gets big, any tube, right, it can rupture. So those are the things that, you want to think about if you have risk factors to evaluate, not just think about your heart when you see a heart doctor.
Now, the aneurysm, aren't those more prevalent in certain age groups?
Yep. So, that's a good question, Donna. So a lot of people don't know. So they come in and they never ask me for it. And sometimes I'll just bring up asking about it. But they'll come in and, they're past the age of 65. They were a smoker. And that's the telltale in their male to evaluate, screen for aneurysm of their abdomen, because that's the higher risk population for that. There are certain people who have family history. If they have a genetic history for aneurysm, so some people would say, there's a history in their family of aneurysms. Some people had brain aneurysms. Some people had Marfan's, Ehlers-Danlos, Lloyd-Dietz. All of these are collagen diseases. Your vessels are made out of elastic and collagen, just like your skin. That's why as we mature, our skin sags and, we lose the collagen and elastin. That's where we lose compliance to our vessel. Well, those factors in these genetic predisposed folks, they don't have the right makeup for that. And so their vessels are very weak and it tends to bulge out. And if it pops, you're going to bleed to death. And there's nothing you can do. That's why it's called screening. You have to screen it and get to it before it pops. Because once it pops, that's it. There's no second chance. It's rare that it does happen. But again, if you have a family history or a genetic history of collagen or elastin disorder, or you have a family history to have aneurysms, and maybe they didn't check their genetics, but they certainly have something, and you have a history of back pain or abdominal pain, or you feel pulsations in your stomach, things like that, just little cues. You just need to let your cardiologist know or your primary care doctor know so they can pursue that further. Because those things you can only screen. If you wait for symptoms, it's already too late.
So we have all this, and we learn more every day about our daily lives and how they contribute to our health. So stress, anxiety, lack of sleep, are these contributory to cardiac disease?
Yeah, that's a good question. It's very indirect. A lot of people don't think about that, but actually that's the major cause. That's why Americans do so bad. We stress a lot, we work a lot, and the Europeans do a little bit better because they take time out for their day. Certain cultures do better because they don't stress. Here's the problem with stress. It's what causes silent high blood pressure, and blood pressure I mentioned earlier is what causes damage to your pipes. And so indirectly, when you have a stressful moment, you don't realize it, but your blood pressure can shoot up to 140, 180, 200. We've seen that. And that causes damage, irrespective of how long, just at that time, that's enough to cause damage to your vessels. But then when you see your doctor, you may not be in a stressful situation, or you may bring a blood pressure log that you only measure when you're not stressed. So it looks good. Your doctor will see and say, oh, that looks great. Your blood pressure is great. They don't get concerned about vessel disease because your blood pressure looks good, but they don't know when you do stress, and you may stress out 20 times, 200 times a day. Those are when your blood pressure goes high and no one knows to treat it. And that's where stress becomes the silent killer. Not only that, stress causes a lot of factors to be released. It makes your vessels more tense. It makes you release more steroids in your system. That causes more salt retention. That causes more changes in terms of dynamics in your body, and it causes more vessel damage. Not just, vessel, but a lot of other damages that occur with it, weight gain and whatnot. So yeah, it's not good to stress. And exercise is a good way to get rid of stress, because we release good hormones, endorphins that make us feel good. We release hormones that make our vessels dilate, improving blood flow to our body. So that's a good way to mitigate stress. Some people go fishing. Some people do things to let go. And then sometimes you just have to have someone to talk to. But I would definitely say, don't hold on to stress because it does hurt you.
Lack of sleep or sleep apnea, is that affected? We did a podcast on sleep apnea not too long ago.
Yeah, we did one a while back. And in relationship to the heart, I just want to reemphasize that again. It's another silent one. So Donna, you've hit all the silent ones. You've hit heart attack, you've hit AFib or irregular rhythm, and now sleep apnea. A lot of people have sleep apnea. They don't know about it. Sometimes you associate it to snoring, but it's not always with snoring. It's when you sleep and you're going into deep sleep and you don't breathe, you stop breathing. So I give an example of that in this manner. When you sleep, we know that we go to light sleep and then deeper sleep and then deeper sleep. Each time we go into that deeper sleep, we breathe heavier and harder. We suck in really hard. Our airways are reinforced with cartilage. A lot of us have different amounts of cartilage in our airways. And that's synonymous to a straw, a very sturdy straw to suck up a Slurpee, and a very flimsy straw that we use to suck up water. Well, think of it this way. When you are sleeping, when you go into that deep sleep, you're breathing so heavy, you're collapsing your airways. You don't know. You're basically sucking in air like a Slurpee, and your airways collapse like that straw because you're sucking so hard on it. Or you may have, a very thick neck, or structural changes in your neck that, extra tissue here and there that causes your airway to fold easily, or your sheer weight. And, a pressed straw tends to collapse much easier than, a non-pressed. So your weight contributes to it too. But in any case, while you're sleeping, you're taking that deep breath, you're in deep phase of sleep. You suck in and you collapse your airway. And you don't know, but you stop breathing. You're dreaming still. Your body gets agitated because your saturations go down lower and lower as you're stopping your breath. And, it puts a lot of strain on your heart, not to mention low oxygen in your body. Eventually what will happen is your body will protect itself. It'll tell you to wake up, to move, to stir, and you'll wake up and go back to light sleep again. But the cycle goes on. It can go on 20, 50 times a night. And you can imagine how much you deprive your body of oxygen. But here's the problem. When you don't breathe, breathing is an active process. It helps the oxygen get into your lungs and the blood get into your lungs. So when I suck in air, I create negative pressure. That will pull air from my mouth in, and it will pull blood from my heart so that the air and the blood meet. When I breathe out, I create positive pressure that pushes the air out of my lungs and blood back into my heart to be pumped to my body. So your breathing actively helps your heart. When you don't breathe, your heart has to push the blood in basically manually. It's already doing it, but now it has to work so much harder to get the blood to your lungs, and you're not letting it. And not only that, you're not giving it oxygen. So it's a double whammy, and so when you wake up, your heart goes into palpitations, irregular rhythms. You just don't feel good. And over time, if you leave it like that, you tend to go into abnormal rhythms that can cause strokes, like we mentioned earlier, AFib. You can cause your heart, your right heart especially, to fail on you. You can end up with heart failure over time. And so, sleep apnea plays a huge role, not just with the heart, but the whole body getting deprived, not to mention cognitive issues down the line. So if you have sleep apnea, which is very silent, right? A lot of us ignore our snoring. We really don't think of it when we go to sleep until our wives or someone watches us sleep and says, hey, look, you stop breathing. That's kind of weird, and then you do one of those shakes or one of those piggy snorts and you wake up and then you go back to sleep snoring, but people don't realize it. It does affect the heart and the body quite a bit. So that's another silent killer that you can look up and evaluate.
Okay, great. Because over the years, you hear people say sleep apnea is not a big thing, or, it's small few. But I think with the work and everything, the way it's going, it's becoming more prevalent. And if it's a way to help keep our hearts healthy, it's a good thing to get checked on.
Yep.
So, Dr. Cal, you're a very special doctor, and you look at things from all aspects. And you're thinking right now, where's she going with this one? We have a lot of patients that don't like to take pills or don't like to do certain things. And I also know that you believe that medicine has a place as much as natural things we can do to help us with hypertension, heart disease, and just our well-being as a whole.
Yep. So, yeah, I do. I would tell you, I was trained Western medicine. And, for the longest time, I never thought about the other side, call it alternative medicine, Eastern medicine. I never thought about something that's not a pill. And, it's a stigma, I think, to a lot of physicians. I don't mind talking about it because I've had firsthand, I was out practicing more in the country, and we didn't have a lot of resources, and a lot of folks out there live quite long, 90s, hundreds, and they do well on their own, and you'd see high blood pressure and you want to treat it, but they're like, doc, I've been like this all my life and I'm good. Why should I take a pill? It has so many side effects. And I agree with them. I can't complain. Every pill it helps, but it also hurts. It also has a side effect profile. Pick a pill, you go online and you have this entire list. So there's a lot of patients that don't want to be on pills. And I begin to, embrace more of a hybrid approach. I still believe in what I've learned because it's scientifically proven, but I also believe that we have a limit. Sometimes we run out of resources and we have to approach something that is a little bit out of the box, but another resource that's available. A family of mine told me, I've always used my left hand, and think of that as Western medicine. And, I'm able to lift someone so far. And sometimes I just need to take the other right hand and do the lifting as well. And I can lift them much higher and get them to where they need to be. So a lot of the patients, they are on multiple pills. We deal with polypharmacy all the time, 5 blood pressure pills or 4 blood pressure pills. And you got to think, sometimes, what is enough, and a lot of them will have side effects from it. And you're using another medication to treat it. Then I start looking into, and thankfully I have some family members and some resources that was able to guide me. And we're still learning. We're learning about it every day towards alternative methods, for blood pressure control, for sugar control. And I would say it's even as simple as minimizing salt, right? You don't think about that. Reducing stress, like we mentioned, those are alternatives. They're not a pill. But it can also be other herbal remedies like hibiscus, to help lower blood pressure, cinnamon to help reduce sugar and blood pressure, natural diuretic to improve your blood pressure because you're eliminating the extra fluid in your body. So, it's a very controversial topic. It's a big field, and it's going to be embraced more in the future, I believe. And a lot of the pills that we have come from these natural remedies. They're just highly concentrated. But because it's a very controversial issue, but I would definitely have an open mind, embrace these new methods, because sometimes, if you can't open a patient with one key, you got to find another route to get into them, to help them. Because at the end of the day, that's what we're here for, is to help the patient, but not stick to, to a sturdy, hey, look, you got to do it my way or the highway. I do believe in being malleable when you're offering care. So that way, your main objective is to get that patient better. So I definitely wouldn't mind talking about this more because this is a big topic in the future. But that's where I would introduce it right now.
Dr. Cal, I just want to iterate, though. Is it safe for a patient to just go in and say, I heard ginkgo's good for me, so I'm going to buy ginkgo? Or, you really need someone that understands what path to go down.
Yes, definitely. I talked about the goodness of herbal remedies, but I also said you have to use it with a certain reason. And that's why, you can't let go of either. You have to use both, remember? Herbal remedies can hurt you too. There are certain things out there, and Donna brought up ginkgo. Ginkgo improves cognitive function. It's a blood thinner too. And so if you're on other blood thinners, for example, and you needed surgery, you need to know you need to get off of ginkgo. Or if you're on other blood thinners, potentially you may make your blood even more thin with the additional herbal remedy that can cause blood thinning. So, and that's just one example. There's many other examples of herbal remedies that affect antiarrhythmics, certain herbal remedies that increases blood pressure, the ones that reduce stress. So there's, you have to probably not just read it, especially if you're taking other medications, because the dosages, how you take it, all matters. So seek professional advice before you do it on your own. The ones that they sell already available out there, a lot of them, the milligrams have already been adjusted so that it doesn't hurt you, but still, you can certainly take more than what is there, and it can hurt you. So definitely seek advice before you do those things.
Dr. Cal, I'd love to have you back on and us pursue that conversation a little bit more, because I think our general community, there's confusion with it all. And everybody has their own opinion. And I think it's prudent that we let everybody know what the choices are so they can make good decisions about their own health.
I agree. Definitely.
It is always wonderful to have you on and talk with you. I could spend hours with you learning about the heart and all the different things that come with it. But we thank you for joining us today. And a big thank you to our listeners for tuning in. Beginning now, set an intention and a relentless focus on living your life as the greatest person you can be in all situations. Please join us next week. And thank you again, Dr. Cal.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.